Hello, everyone. Today, as a Japanese WTD event, we have planned an interview with Professor Hunt. Professor Hunt is in Japan as an invited speaker at the annual meeting of Japanese Society of Hematology. Our interviewers are Professor Urano, a former WTD member. Please raise your hand. Dr. Ikezoe, Professor Ikezoe, Professor Suzuki, and myself. Hello, Beverly.
Hello.
Thank you for coming our interview. We would like to ask you about the summary of the 10 years of WTD activities and what you have learned from COVID-19. And finally, we would also like to ask you about what our activities of Japanese WTD should be in the future. Yeah, please start your presentation.
So just small questions then. So I've got a few slides on World Thrombosis Day, which Eriko and Tetsumei know very well. So to remind you all that World Thrombosis Day is the 13th of October every year, and it was started at the end of 2013 and really initiated in 2014 by the International Society of Thrombosis and Hemostasis. They wanted to have an arm where they could address the public and the world about thrombosis. So it's been about increasing awareness of thrombosis, including what the risk factors are and the signs and symptoms, especially of venous thromboembolism, and trying to help the World Health Organization reduce the global burden of premature death. So it's on October the 13th because that's Rudolf Virchow's birthday, and we all remember Virchow's triad, showing us the risk factors for venous thromboembolism. So we look at the objectives in more detail. We need to get the message out there that 1 in 4 deaths globally are due to thrombosis, and to make more people aware of the risks and the signs and symptoms of venous thromboembolism and also atrial fibrillation. And we want to empower individuals to understand these conditions so that they can present early or they can prevent having these problems. This is a global movement. We need to collaborate with all the countries across the world, and also in particular with the World Health Organization, who will help us disseminate information. And we want to advocate for systems of care so that, for example, if you go to hospital anywhere in the world, you will be risk assessed for your risk of hospital-associated thrombosis. So over the last 10 years, Gary Raskoff was the first chair of the steering group. I followed on, and I was very much helped by Claire McClintock, who sadly died last year. And now the chair sits with Lana Castellucci, who is based in Canada, with Eric de Paula, who's based in Brazil as the vice chair. So we have a colossal reach, and the team associated, the office team, have won prizes for taking this campaign from nowhere to this massive outreach. So these are figures from 2022, and you can see we reached 10.5 billion people with enormous numbers of impressions on social media and other types of media, and we have 11,000 partners. We encourage people to join the movement, and those partners have been running events, and we expect an even better performance this year. So this was our last steering group meeting in San Diego in January, where we sat down and we planned what we were doing for the next year and also beyond. This is a very solid campaign now, and we need to have plans to push on and progress awareness and also to work with the World Health Organization. So this year, we've been working with partners. There's ongoing social media work. Because these days celebrities seem to be so important in advocating various groups, we engage with celebrities. For this World Thrombosis Day, there's an interview with Melanie Bloom about the sad death of her partner, David Bloom, who died of a blood clot. We've also had much more of a mental health focus. So we had a global webinar on World Mental Health Day to explore the psychological aspects after thrombosis. And yesterday there was a clot chat and a 60 for 60s fitness challenge from before that to encourage people to get moving. And also academically, papers are being published regularly. So we hope you all will take part in World Thrombosis Day this year and next year and be aware of this amazing movement to make your patients more aware of their illnesses. Thank you. Now, I was also asked to talk about COVID. COVID and coagulation is an enormous topic now. I'm going to give a little overview. I have some conflicts of interest. They're not financial. It's just that I have been in the UK part of the National Institute for Clinical Excellence COVID guidance. I actually do a lot of work for the WHO at the moment. I co-chair the guideline committee on COVID-19. We're very active at the moment looking at the antivirals. I advise our Royal College of Obstetricians, and I'm part of the writing committee of REMAP CAP, who did some of the studies. So what I would like to talk about is acute COVID, then vaccine-induced thrombocytopenia and thrombosis, and lastly, the strange tales around long COVID, post-COVID condition and microclots. So I think we all know pathogenesis of acute COVID, and we know for most it's a mild illness, but for a minority in the UK, in the first wave, it was up to 5% of the population, reflecting our ill health, who developed COVID pneumonia and the profound prothrombotic state associated with it. Now, this is a heat map from the UK showing the deaths due to COVID-19. So all those who had COVID pneumonia, and the y-axis shows the age, and then the x-axis shows over time. And what you can see, the dark colors reflect high rates of death that in the UK, and this is true globally, this is a disease that killed older people. And so the first wave, we had a lot of deaths. Then come January 2021, we had Alpha. And then moving on, October 2021, we have Omicron causing lower rates of death, but still significantly increased numbers in the elderly. And we all know that venous thromboembolism has been a major problem, not for those with mild COVID, but those who've been admitted to hospital, and especially those in critical care. Now, this is the Swedish data. They looked at all their rates of VT with COVID, and you can see that the rate of DVT when admitted to critical care was 30 times the background risk. And then for pulmonary embolism, it's 289 times the background risk. Now, this is actually not quite true, because when we look back, we know when we got a positive CT pulmonary angiogram, we were counting two things. We were counting pulmonary emboli and also immunothrombosis. Oh, incidentally, I spoke a lot on media about COVID. I don't know if you recognize Voldemort or Ralph Fiennes here, but he acted in a play written by one of our playwrights who heard me on the radio, and every day he had to talk in the theatre about DVT and PE that was seen, and also quote some of my words, which was very nice. So let's come back. We had two lung pathologies, two thrombotic lung pathologies in acute COVID. Yes, good old Virchow. We've got pulmonary emboli, but we've also got immunothrombosis. That's in situ thrombosis that you see in acute respiratory distress syndrome, described in 2013 by a group of intensivists, but they didn't actually tell anybody outside the field. So it's a new discovery for many of us. And when we look at the COVID patients, they had enormous prothrombotic state. So this is our first 60 ventilated patients, Klaus fibrinogens, somewhere between 5 and 12 grams per liter, normal range being up to 4 grams. And then D-dimer levels enormously increased, and that's actually a logarithmic scale for them. And they went up and down with the acute phase proteins, which are procalcitonin, ferritin, and CRP. So an amazing inflammatory response. Just coming back to immunothrombosis, it reminds us that coagulation, thrombosis formation, is the end point of the immune response. So in areas of high inflammation in the lungs, and if you've ever looked at the lung pathology, it's full of macrophages and lymphocytes, you would get thrombosis in the small vessels. And it's something we've seen before. We see it in Behçet's disease, we see it in vasculitis. And when we manage those patients, we treat the inflammation, we put them on anticoagulation, but it's actually reducing inflammation that reduces the rate of immunothrombosis. But on top of all that, unfortunately, the patients with COVID pneumonia often were very hypoxic, and the hypoxia will drive a prothrombotic state too. So when we look at the rates of thrombosis in the COVID patients, we've got the COVID patients who required ECMO at our unit versus those from previous years who had influenza. I would like you to look at the third row. You will see that the rates of immunothrombosis on their CT-PA scan when they started ECMO were much higher when they had COVID, and at the bottom, when they come off ECMO, the rates of DVT were much higher. So essentially emphasizing that COVID probably produced the most prothrombotic state we have ever seen with a viral infection, or indeed bacterial infection. So how did we manage it at the start? Well, we are all in Europe using low molecular weight heparin for thromboprophylaxis and critical care, and we didn't know what to do. This is the WHO guidance from the time. It said carry on using standard thromboprophylaxis. The ISTH came out with some guidelines and said, well, maybe you could try intermediate risk or either intermediate levels of low molecular weight heparin or even full low molecular weight heparin to try to stop them thrombosing. And it really took until the end of 2020 for the REMAP-CAP platform study joined with Active4A and the ATTACK study to show that if you gave therapeutic anticoagulation with heparin to your patients, there was no different outcome clinically than those on standard thromboprophylaxis. And the problem was, if you gave therapeutic doses, there were much higher rates of bleeding. However, in those who are just hospitalized and didn't need to be ventilated and only need supplementary oxygen, there was a different result. So we've got a different result for a different group of patients with COVID. Those who just required oxygen, a group we called moderate risk, did better with therapeutic anticoagulation with an acceptable bleeding rate. Now, when we looked at other studies, this is a study using rivaroxaban in Brazil to see if it would help prevent thrombosis. It gave no added benefit, but a very significant increased bleeding risk. So it seems as though heparin in COVID pneumonia, in the early waves, when people weren't vaccinated, where we weren't using systemic steroids, had a beneficial effect. And it may be that it's not because heparin is working as an anticoagulant, but working as an anti-inflammatory agent. We know heparin has got major anti-complement activity. And then we have the recovery study that looked at the use of aspirin in severe COVID, no benefit. But for every 1,000 patients treated, 6 more had major bleeding. So aspirin should not be used. Not supplementary. Aspirin should not be used in acute COVID. So where are we now? Well, we're actually dealing with Omicron, which is very different. We have a population that's fully vaccinated. We've got another new variant in the UK, which we call Pi. Very few hospital admissions, and most of them do not require ventilation. They're on the wards getting oxygen, and they get steroids and anti-IL-6 drugs. And we do use full-dose low molecular weight heparin in this group. And I think what I've learned, and a lot of us have really been surprised about, was this heterogeneous effect of therapeutic anticoagulation. So we've given the same medication to a group of patients we thought were all the same, but we had different outcomes. And this is really a warning for future clinical trials, that we have to be careful that we have, and we look at subgroups to check we're not having a different effect with the same drug in the same disease, but in different patient groups. And the other thing that COVID did is highlight hospital-associated VTE. COVID is the best example ever of hospital-associated VTE. So I worked very hard during the COVID pandemic, and we were trying to recover in 2021, and then we became aware of this phenomenon of vaccine-induced immune thrombocytopenia and thrombosis. These are 2 cases in my hospital in March and April 2021. Very sad that the first, a 28-year-old woman, she was vaccinated with the AstraZeneca vaccine. She had a severe headache 14 days later, and a venogram showed extensive cerebral venous sinus thrombosis. So this just wasn't one vessel, it was the whole of the venous system. Platelet count 16, D-dimers 6,000, low fibrinogen. We admitted her, we treated her with intravenous gamma globulin, but very quickly she developed intracranial bleeding and was declared dead. On the right, we've got a 41-year-old man, again vaccinated with AstraZeneca. 6 days afterwards, he presented with ischemic legs, platelets 42, D-dimers very high, fibrinogen below normal for us. He was given intravenous gamma globulin and orgatroban. We weren't using heparin. He rethrombosed. He went back to theatre. He rethrombosed. We went back to theatre. And at the end of the day, I think he lost his forefoot, so managed to retrieve most of his limbs. So in the UK, we recognized the problem like everybody else, but we had many more patients receiving the AstraZeneca vaccine than most. And you either were able to get Pfizer or AstraZeneca. So we formed a group of experts in hematology. You can see us all exhausted at the end. Mike Macris, Sue Pavard, Claire, Marie Scully, Will Lester and myself. And we every day at 2 o'clock, we had a virtual meeting online, and people from the UK, usually hematologists, would present the new cases. We learned about the cases, and we learned about the best treatment. And at the same time, we wrote living guidance. We worked with our public health agencies, and we also looked back to see, because we had been using AstraZeneca since the end of December, if we hadn't missed any cases, because it was a new phenomenon then. We spoke to our emergency physicians about how they should manage the very many worried people who had AstraZeneca vaccine and then came to the hospital with a headache 5 to 10 days later. And our guidance was finally converted to NICE guidance, and it's still on the NICE website. We wrote up our experience of our 300 plus patients. It's in the New England Journal, and we defined definite VIT with 5 criteria. You have to have onset of symptoms 5 to 30 days after the vaccine. You have to have time to develop the antiplatelet factor 4 antibody. So timing, thrombosis, thrombocytopenia, very high D-dimer levels, and the critical positive antiplatelet factor 4 antibodies on ELISA. And then we said, if you've only got 4 of those probable, 3 possible, and the rest were unlikely. On the left, we have how these patients presented. 50% had cerebral venous sinus thrombosis, 30% had splanchnic vein thrombosis, and they might just have a portal vein, but quite often they had all the splanchnic veins involved. Only 10% had DVT and pulmonary embolism. They tended to be older. So when we went through the patients, I haven't got time to talk about the intricacies, but we were able to say this patient group is worse. They were particularly cerebral venous sinus thrombosis with particularly low platelet counts. We started plasma exchanging. What came through, which we were surprised about, was there was no obvious precipitating factor. And many of these patients had never had any problems before or any comorbidity. Just to remind you, with heparin-induced thrombocytopenia, which is the sister problem, the heparin acts as a hapten with platelet factor 4, and an antibody develops which can activate platelets and endothelium. And Andreas Granetscher in Germany, who worked day and night, demonstrated that it looked like the adenoviral vector itself was probably the hapten in this case. And you've got a picture of green and purple on the upper left. The green is the adenoviral vector, and the purple is platelet factor 4 binding to it. We learned such a lot. When you have a new illness and you're learning day by day, we soon learned that the 6 ones needed plasma exchange. So we would give them intravenous gamma globulin. If their hospital did not have plasma exchange, we would transfer them over to a hospital that did, and they recovered much more quickly with less problems. When we look at the antibodies, we still have, and this is what we're 2 years on, patients who still have a persisting antiplatelet factor 4 antibody. And it's hard to know how long they're going to last for. They don't appear to be pathogenic. We've stopped anticoagulation in some, but they still have an antibody. Now, we've know a lot from the international community. We know that on the platelet factor 4 molecule, the antigen that's precipitating the VIT is a different site from the antigen that precipitates HIT. So we've got heparin binding sites here. The blue is where HIT tends to bind, and the red where VIT tends to bind. Having said all that, we know that VIT is very, very rare, and we have got a national program, which I'm part of, and we are GWASing, we're genotyping all of our patients to see if they've got some factor which makes them prone to have VIT. So we only saw 1 in 50,000 in young people and 1 in 100,000 in older people. And young, I mean under the age of 40. However, we don't use the vaccine anymore. The J&J adenoviral vaccine in the States isn't used anymore. It causes the same problem. But globally, AstraZeneca vaccine is the most widely used even now. They're still using it in Brazil and in the far end or India and around there. Now, this is not the end of the story, because we now know that maybe over the years we have been missing some cases that are very similar to VIT that have occurred after adenoviral infection. And Ted Wilkenting has published in the New England Journal 2 cases. This is the left, a 6-year-old who got a VIT-like illness, and on the right, a 60-year-old woman. Both had adenoviral infection and both got the same syndrome and responded to treatment with steroids, intravenous gamma globulin, and plasma exchange. So this is an ongoing story. Is it that over many, many years, we have missed cases of thrombosis with thrombocytopenia due to an antiplatelet factor 4 antibody occurring spontaneously? And the other problem we have in the UK, I started a charity. We have a clinical psychologist we employ who supports the patients who've had VIT. They have many problems. They have physical problems, and all of them are tired. They have fatigue. They feel unwell. They feel unable to work. And in the UK, nobody wants to hear their story, really. And so they don't feel supported by friends and relatives, and our government are not offering them more than a very small amount of money. So we are, on the charity side, campaigning to improve the compensation they get and to offer psychological support to them. And also, I think some of them might benefit from therapy for fatigue. So now the last place we're going is the post-COVID-19 condition. Poorly defined, this is the international definition from the World Health Organization, and it's individuals who've had COVID who have persistence of symptoms for at least 2 months where there can't be an alternative diagnosis. And the commonest symptoms are fatigue, shortness of breath, and cognitive dysfunction, all affecting their day-to-day functioning. And there has been, over the last year, a thought that blood clots could cause post-COVID condition problems. Post-COVID condition is also known as long COVID in the UK. And in the UK, we have many desperate people who've got really poor quality of life, who find it difficult to get up from the bed and exhausted all the time. They have been going off to mainland Europe to have apheresis to remove what? And this is not regulated, and there are no clinical trials to support it. So with the BBC, with the one of our news channels and the British Medical Journal, we've investigated this. And the science behind it is that this is due to microclots in the bloodstream, and they are hypothesized to cause a shortage of blood flow to blood tissues and account for the symptoms of fatigue and brain fog. So I don't know what you're saying. I see long COVID patients because I've always been interested in chronic viral infections. They're not having heart attacks, strokes, or DVT or pulmonary embolism. They're not having microthrombosis. There is no signal coming in from UK data or admissions I see in hospital where patients with post-COVID condition are being admitted with macrothrombosis. So we explored the data backing this theory in a Cochrane review, which was published last month. And we looked at the studies that said microclots were responsible. And there were 5 studies, and they're all from the same laboratory. Now, this laboratory is actually looking for amyloid. So what they are doing is they are using a fluorescent dye, and they are identifying amyloid microparticles. They have been working on this for years, and they have identified these microclots, as they call them, in maturity onset diabetes, in acute COVID and post-COVID condition. And myself and Robert Ahrens have also shown that they're present in patients after pulmonary embolism. So the first thing to say is they've been found in lots of diseases. They are not unique to post-COVID condition, which makes saying this might be the cause a little bit problematical. And the second issue is none of the studies have used scientific methodology. They've either said they are present, but they're not present. And some normal people have these microclots, and the studies don't differentiate between those who are normal and what the size are in normal people with those who've got post-COVID condition, acute COVID, and maturity onset diabetes. We have chosen to call them amyloid fibrinogen particles because they've got little bits of fibrin attached, or fibrinogen, but they're not clots. The bulk of them is amyloid. Amyloid does not take part in coagulation. So we felt that the rationale for these particles being the cause of long COVID is not proven. It definitely needs more research, and this may be a red herring. I think it's a reflection of how desperate the patients are, and this group, they deserve high quality research. We know acute COVID has got this amazing prothrombotic state. We're not seeing this in those with post-COVID condition. Some of them have very minor changes. So this study from University College shows they have slightly higher levels of von Willebrand factor and slightly lower levels of Adenovirus 13. This is not a major change that would account for their symptomatology. So just to summarize, what I think COVID has taught the world, among many, many things is that we can all cooperate together to do clinical trials. That's the only way we managed to get REMAP-CAP finished. We need to think about the design of clinical trials again. Is it that a drug can affect one part of a group of people with the disease and not the other? That's what the heparin trials have shown us. And that hospital-associated clots are common and need treating. For the vaccination-related clots, we need to think more. Have we been missing this disease in the general population? In the UK, we've got to sort out compensation for our vaccine-related injuries. And in long COVID, we really need an international research effort to look at the etiology of long COVID so that we can offer appropriate treatment. Thank you.
Thank you so much for excellent presentation, Beverly. Yeah, let's talk about our presentation. Do you have any question, Professor Urano?
Yes. First of all, thank you very much for your excellent talk. I'm very much impressed by your effort to, share your information about VITT and such information and guideline which was quickly shared by other people. That contributed so much to decrease the mortality of VITT. So I think such things also needed for the the other thrombotic condition like hospitalized the VITT, hospitalized DVT. World Thrombosis Days campaign contributed so much, but still we need something to increase the awareness of such risk among the people who are working in the medical field and also patients.
Yes.
So from such experience, that you worked in WHO, right, for COVID-19 issue.
Yes.
But for the other thrombotic disease, I think it's better to include the either government or administration.
Yes. We need to persuade governments that they must think about thrombosis in educating children. And we need the WHO to also be saying to them, hey, you need to think about this too. So we must have more awareness at all levels.
Yeah. Okay. And also regarding to VITT, you mentioned the spontaneous adenoviral infection, maybe also related to similar, the symptoms or the disease. Then you mentioned the in VITT criteria, the symptom develops from 5 to 30 days after vaccination.
Yes.
But do you have any patients who developed earlier who may have their antibody after spontaneous adenoviral infection?
No. That's too clever. No, we haven't seen anybody before 5 days. I think that the spontaneous fits after adenoviral infection is very, very rare. I hope it's very, very rare too. But no, we didn't see anybody like that.
Can I have one more question about the post-COVID?
Yes.
Somehow, if microthromby is related to the symptoms, is there any study who used DOAC or for the, you know, the
Yes.
for the
So
prevention.
in London, if you go to a private clinic, you get aspirin and a DOAC, among many other things. There's no evidence for that. We also have a big post-COVID clinical study going on, and one of the drugs will be, I think, rivaroxaban, or it could be apixaban, I'm not sure. But these studies are very slow to set up and recruit.
Do you have any?
Yeah, Professor Han, thank you very much for very interesting talks. So you said still some developing countries, including Brazil and India, are using adenovirus vaccines. It's a program. So I think the developed countries such as UK or Japanese government should provide mRNA vaccines to such countries. What do you think about this?
So there is an international collaboration for countries to be donating to low-income countries, but it didn't work particularly well. So people did promise that they would give vaccination, but it didn't always arrive. I think the other issue in low-income countries is that many people don't want the vaccine.
Don't want that.
Yes, I mean, there's an anti-vaccine movement, as you know. The problem is that in the UK, the mRNA vaccines are about £30, and the AstraZeneca vaccine was £4.50. So the cost is tiny, and it was actually AstraZeneca who wanted it to go out to the rest of the world. They weren't expecting this. So they very much did it in a spirit of helping the rest of the world. Very sad.
So I have one more specific question. So I was really interested in the story about amyloid fibrin in
Yes.
PCC.
Yes.
There are several amyloid. So what kind of amyloid is this? AL amyloid or other amyloid?
So it's just amyloid. Yes, I mean it's lumps of amyloid, and I think they're beta pleated sheets. And there's no more about it. The lab have produced data saying, well, they're in long COVID, but they're in acute COVID, they're in diabetics, they're in normal people, they're in people with pulmonary embolism. So it doesn't seem to be correct that they are the cause of long COVID, because normal people aren't fatigued, people with diabetes aren't fatigued, they don't have the same range of symptoms.
Yeah, me too. This is the first time to hear the amyloid fibrinogen title. Yeah, it's very interesting to relate with
Post-COVID condition.
Thank you very much. It's a great talk, and I'm very, very impressed with the talk. I also want to know, we can rise such fibrin amyloid complex?
No,
No.
amyloid is resistant to fibrinolysis, yes. But it's not the cause of long COVID. I talked about it to warn you. This is not the cause of long COVID, as far as I'm concerned.
I have a question. In my opinion, platelet is a very important factor for development of thrombosis with COVID-19. And why wasn't antiplatelet therapy to prevent thrombosis in patients with COVID-19?
So it demonstrates the need to do clinical trials, because when you look at acute COVID, the platelets are very activated. So if you look at any the platelets in any way with any test. They're very activated in acute COVID, well, in severe COVID. But you need to do a clinical trial to show that giving an antiplatelet agent has benefit, don't you? And this trial showed no benefit and a significantly increased bleeding risk. So that's why we do clinical trials, because otherwise people might say, oh, well, they've got activated platelets. Let's give them all aspirin. And of course, there is no benefit. Why? I suspect the platelets are so activated, aspirin is doing very little.
Yeah, again, about the VITT, what is the most difficult part for you to, after, discussing about the symptoms and the effect of therapy among the people in the UK, what was the most difficult part?
It was at a personal level. It was exhausting. Every day we did the call, Saturday, Sunday, bank holidays, and we'd start at 2 o'clock, and quite often it went up to 4 o'clock. And so I couldn't do my routine work, and then I had to do that later. So, and it was the same for all of us, but it was the only way of learning about every single case and working out the best way forward. And of course, some of the patients were my patients and had sad outcomes, so not a good time.
Yeah, that was very much impressive.
Thank you.
And then what should we do, in the future for as an World Thrombosis Days, the campaign, or what can we, tell the young people, the young scientists to do in the future?
Well, you could have a stand at the Japanese Society for Hematology. You could do a video, you could do a run, you could have a tea party, you could have a lunchtime event here at this meeting for World Thrombosis Day that everyone was invited to, and they had their bento box there. And I think we just have to keep trying to pull them in, don't we?
That's right. Yeah, actually, it's a little bit hard for us to conduct several meeting or lunchtime with young scientists or severe people. Yeah.
Do you have a patient group in Japan? No.
Not
No.
start.
So maybe that's where you start, because I set up Thorombosis UK. So we have run a series of lectures this week. And we have given a pack of information to each interested hospital, and they have run a stall in the hospital. So you come in the entrance and there's a stall saying World Thrombosis Day, and they'll talk to patients and they'll talk to staff about it.
Yeah. Yeah.
It's hard work, but it gets somewhere.
Yeah, we should stand. Thank you so much.
Thank you.
For coming to our interview. Last speech, Dr. Urano.
Really, thank you very much for your coming to Japan and also having such time. It was very much impressive. I think it can, inspire the many young scientists in Japan.
And
Thank you
I'm
very much.
just about to go and talk about a very inspiring Japanese doctor for my talk on tranexamic acid, because you do have inspiring doctors. Thanks.
Thank you so much.
Thank you very much. Thank you.